Okay, for recording purposes, good morning, everybody. It's January 20th, 2022. Today's topic is high-risk spine protocol with Dr. Levy. Is that what you were saying? Sarah, thanks for being our speaker. And make sure you can see. Oh, that didn't help. All right. Do you have notes that you need to do like a, okay, you can just toggle that way if you want. Otherwise, we can have a different, oh wait, you're fine. Start slideshow there. Hi, video panel. Okay, try it from there. And if this hides your material, we can try again. But are you able to hit to the next slide?
Yeah, I think. Yep.
Okay.
Hi, everybody. I think I've met all of you at this point, but I'm Sarah. I'm one of the CA1s, and I've been on PACU for the past couple of weeks. This morning, I'll be talking about the high-risk spine protocol. I'll go over a little bit about which patients are considered high risk, how we prep these patients preoperatively, how we deal with them in the intraoperative setting, and then probably more relevant to all of you, pain control during surgery and then afterwards. As I mentioned, about 10 people said you should include a ton of pictures of your pet. So this is my dog, Ruben. As you can see, he's a very good listener. And so he was instrumental in creating this presentation. Ruben. Thank you. So which patients undergoing spine surgery are considered high risk? Patients can be deemed high risk from either a surgical or an anesthesia perspective. So from a surgical standpoint, high risk patients are those who are undergoing revision surgeries, those who are undergoing fusions of over 6 spinal levels, whenever there's a tumor excision, and then all procedures that are combined anterior and posterior approaches. From an anesthesia standpoint, high-risk patients include those with multiple medical comorbidities or poorly controlled medical comorbidities, patients on chronic high-dose opioids, and then young patients under the age of 18. So for pre-op preparation, this really centers around preparing for substantial blood loss and the potential for transfusion in the OR. So access is really, really paramount. So all of these patients will come out to the PACU with an arterial line, which is placed both for hemodynamic monitoring and for serial ABGs to be drawn in the OR to guide transfusions. Also, these patients will come out with large vascular access. The specifics of this is just determined by each individual anesthesia team, but generally the patient will have multiple peripheral IVs, generally of larger gauges, and they may or may not have a central line depending on the anesthesiologist's decision. And then all these patients are type and crossed, and blood products are available in the OR prior to the start of the procedure. So intraoperative management, again, frequent ABGs are drawn. For you guys, this may continue in the post-op area there. If the surgical team thinks that, and the anesthesia team thinks that hemoglobin needs to be, trended further. And then often patients are positioned prone. There are some cases where the approach is anterior, and there are cases where patients will flip back and forth. But some post-op considerations, I know you all have pretty extensive experience caring for patients who have been in prone surgeries, but they can come out with pretty substantial facial edema, scleral edema, which can be rather jarring for patients. There's also a really rare risk for extended prone procedures of vision loss. We maintain euvolemia and normotension to really avoid this, and this should be discussed with the patients during the consent process by the anesthesia team. Something kind of unique to these spinal procedures is the neuromonitoring, which I'll again go over very briefly. But the two most common types of neuromonitoring involved in these cases are the somatosensory evoked potentials and then motor evoked potentials. So the purpose of neuromonitoring is to assess the integrity of the spinal cord and assess that sensory and motor function during surgery to make sure that these pathways aren't disrupted. So for somatosensory evoked potentials, over here, electrodes are placed on the periphery and stimulate peripheral nerves, and then this signal ascends the dorsal spinal cord via the posterior columns into the sensory cortex, and then this cortical response is measured. Motor evoked potentials kind of travel the other way. electrodes or magnetic stimulators are placed over the motor cortex. And then the signal will descend the spinal cord ventrally to the peripheral nerves and then to the muscles. The motor impulses can be measured at several kind of sites in this pathway, including the muscle itself or sometimes in the epidural space. And just very briefly, this neuromonitoring influences our anesthetic choice in the OR. The inhaled anesthetics can often interfere with this type of monitoring. So that's why we generally use IV agents in these patients. Also, when the motor evoked potentials are being performed, we will avoid neuromuscular blockade. So you'll maybe, like if you're looking back in the patient's chart, you'll see like maybe rocuronium is given to facilitate intubation, but then is reversed really, really early on, or sometimes Sugamidex is used, which is a much shorter acting agent. So maybe more relevant to you, this is a picture of these peripheral electrodes that are placed by the neuromonitoring team. So patients will come out with kind of like pinpoint areas because they do stick into the skin. So if patients have questions about that, that's likely from the monitoring electrodes. There have been reports of really rare complications of areas of skin irritation and pressure ischemia in response to these electrodes as well. And then something else to note, just to be aware of with your patients coming out of these surgeries, is that when motor evoked potentials are used, the currents that are placed over the motor cortex can stimulate the temporalis muscle and cause forceful jaw contraction. So there's a risk of like intraoral injury, biting the tongue, biting the endotracheal tube. So that's why in the OR, we use these soft bite blocks, usually just like made of rolled up gauze and tape that we push way back in the molars, but they can sometimes be displaced, especially if the patient is being repositioned frequently. So analgesia, many of these patients are undergoing surgery for some type of chronic back pain. So pain control can be a really big problem in these patients, especially because they're undergoing these relatively large procedures. So at the minimum, the patient's daily morphine equivalent requirement should be met. However, we generally kind of overshoot this in the OR. Morphine equivalence, as I'm sure you all know, it's a value that's assigned to different opiates to kind of describe the potency relative to morphine. This is a chart kind of showing those relative doses and the morphine equivalents, the equivalent of 1 milligram of morphine. There are a lot of charts, but there are also some really great online calculators as well. So multimodal analgesia is often used, again, because pain can be a really big problem in these patients. Preoperatively, oral Tylenol, gabapentin, and Celebrex is often given. And then intraoperatively, there is kind of a menu of all these different IV agents that are used at the discretion of the anesthesia team to kind of get ahead of the pain. This is a protocol from PolicyStat that really maps out pain control in a subset of these high-risk spinal patients. This is written by Dr. Frauman, who I think is on the line. So if we have any questions, hopefully he can help us answer them. This protocol, the neuroanesthesiology lumbar fusion perioperative pain protocol, applies to patients undergoing non-traumatic low thoracic through lumbar complex spine surgeries. To qualify for this protocol, patients must be between the ages of 18 and 70 years and must have a 12-lead EKG within 90 days to assess for the QTC. Preoperatively, this protocol is kind of the same as I talked about earlier. These patients will receive PO Tylenol, gabapentin, and celecoxib in the pre-op area before going back to the OR. I apologize for this dense slide, but I couldn't find a better way to present this information. Intraoperatively, something that's relatively unique to this protocol is the use of methadone. This is dosed at induction. There are different doses for opioid naive patients compared to opioid tolerant patients. I think someone mentioned that we don't often see methadone use, so there was some question, well, how does that affect post-op opioid administration? During the surgery, long-acting opioids are avoided just because methadone itself is a long-acting opiate, so it's hard to kind of assess the patient's level of narcotization. However, in the post-op setting, which I'll go into a little bit after this, it shouldn't really impact the use of long-acting opiates, and actually morphine is one of the main agents used for this protocol after surgery. Methadone is avoided, however, in patients with a prolonged QTC, so that's why that EKG is done preoperatively. Usually the surgeons will perform some type of preoperative field block using bupivacaine and clonidine, and then remifentanil is generally used in addition to IV propofol to kind of keep the patient asleep and comfortable, especially when no neuromuscular blockers are used. Ketamine is sometimes used, sometimes not used, again at the discretion of the anesthesia team, but is generally avoided in patients with a history of schizophrenia, psychosis, active suicidality, or severe valvular stenosis. And then IV Tylenol is generally dosed at 6-hour intervals throughout the course of the surgery. Post-operatively, most of these patients will be prescribed a morphine PCA, which all patients, as I know you all know, should be on a continuous pulse ox if they're on the PCA. Again, it's okay to use this long-acting agent because the methadone was dosed much earlier in the case, and the patient is awake. It's easier to assess the patient's mental status in response to the opiates. Oral opiates are started after 24 hours, generally using oxycodone 5 to 10 milligrams Q4, but this is titrated based on the patient's amount of pain the patient's having. Tylenol, gabapentin, and celecoxib are also redosed within the several days following surgery, as well as magnesium. And then the surgical team, sometimes not, will prescribe muscle relaxants. But again, that's at the discretion of surgery, and it should be avoided in patients who have concurrent benzodiazepine use or methadone use. Exclusion criteria for this protocol include patients who have a really, really high baseline opioid regimen of over 90 milligrams morphine equivalents per day. Pregnant or breastfeeding patients should be excluded, patients with symptomatic heart failure, patients with pulmonary disease necessitating home oxygen therapy, those with active liver disease, cirrhosis or hepatic failure, renal insufficiency, history of recent falls, and then super morbid obesity defined as a BMI over or equal to 50. Here are some citations, mostly for images that I used. A lot of this information was from policy stat and the policies that were made by Dr. Frauman and others. So thank you very much for listening, and thanks for a great couple of weeks.
Hey, Stark, can you hear me?
Yes, I can hear you.
Hey, great presentation. You hit all the high points. I just want to clarify one or two things just for the nurses, just because there's a couple of issues that they wanted to address with me that I want to do in particular.
Sounds good.
You're correct. You're correct that morphine should be used. It's okay to use it. One thing in the perioperative period.
Hey, Dr. Frauman, can you wait 1 second? We're just hooking up a speaker so everyone can hear you.
Of course. No
Anybody else
whatsoever.
who's on the line might want to mute if you can.
Okay, you can Dr. Frauman.
All right, perfect. Sorry, and again, sorry I'm not there. I actually got COVID positive last week, so I am on a long-term hold before I can come back. I'm going to come back next Monday, so I apologize that I'm not there in person. Excuse me. The biggest thing, the one change that's unusual about use of methadone, the patients generally are going to be coming out without pain. So preemptive analgesia in the perioperative period isn't required. I know that's a change a lot of times. If they come out wide awake and screaming, it's one thing. But intrinsically, you should not consider them to have acute pain requirements in the immediate postoperative period. We actually only use the morphine PCA for the ability to get 24-hour pulse ox monitoring in the perioperative period. There wasn't an order for it that was easily accessible or easily accessible by the neurosurgery residents. So Doug and I made the decision to put the morphine PCA on board, but it should be by request only for pain. We've had it in the very start of this is now 3 or 4 years ago. We did have a couple of patients come back and end up having to be either mask ventilated or re-intubated In the PACU, we haven't had a circumstance like that again since we clarified that a few years ago, but do be very careful and judicious on whether or not morphine is going to be used in the PACU. It really should be by request only, which means that the patient should have the demand of the PCA, but not have preemptive analgesia used. I just wanted to clarify that one point. That is the real risk that Doug and I are concerned about. We've actually got to do a retrospective study now to look to see if we've got any issues with our respiratory arrest up on the floors. We have not heard peripherally that there have been any, but that is the one area of concern that if you see people using methadone, it's the one that people will be concerned about. One other thing, methadone is starting, the literature started coming out about 2 or 3 years ago with a guy named Glenn Murphy. If anybody is curious where this came from and why you're starting to see IV methadone used in the intraoperatively now, it's a guy named Glenn Murphy. There's a couple really good review articles by him on IV methadone use in anesthesia. It has become more prevalent. It's still very low likelihood that you're going to see it outside of these written protocols. But if you do see IV methadone used, it is a great drug. The benefit of it gives you, it's a variable half-life, but it gives you about 24 to 96 hours. So it really is patient dependent on the duration of its action, but it will be there for the first 24 hours and really gives a good baseline analgesic for the patient in the perioperative period. And with all of the reduction of IV opiate use in the past few years that have come up, it is a drug that I think you're going to start to see a little bit more frequently, not only in the spine protocol, but in other patients as well. There are a couple champions of it out there that are starting to come forward. Laurel Moore is one of them. She used it a lot in Hopkins in her early stage, in the early stages of her career. So just as an FYI, you may start to see methadone being used more and more, not only for spine surgery in this protocol, but in general surgeries as well.
Thank you, Dr. Froman.
Thank you. Do anybody else have any questions, either for Sarah or Dr. Froman, or any other insight?
I guess would just be to make sure that that's like very clear in the handover that they have a long-acting IV methadone.
Right, yeah.
Is that part in the centricity paperwork that we found?
If you guys, I don't know if either Bob, if you want to answer this, if you guys use the methadone, does that print out on the centricity handover sheet that essentially as PACU nurses receive? I don't know if you know that.
Yeah, so Sarah, have you been in a surgery with me where we've used IV methadone?
No.
So it is actually double charted. It is one of the drugs that is double charted. It is ordered in pharmacy, and it is CST controlled, but it is not just a pickup drug that's in the Pyxis from the anesthesia chart. It is something that does have to be double charted. So you will see it both yes, you should see it in the centricity record, but you should also see it in the MyChart record as well, in the MAR. So you should see, this is one that is very tightly controlled. You don't see it that often, and it should absolutely be signed out by both the resident to the PACU nurses that it's being used.
Chronic abusers?
I didn't hear that.
The question was, do we ever use IV methadone for chronic opioid abuse in the
So Sarah, the
area?
big thing one of the issues that Sarah brought up that is absolutely correct is that your baseline opiate use should be taken into consideration for all surgeries going forward. So if a patient is on methadone, so if they're on oral methadone, they should have taken their methadone in the morning. If they are on a large dose of oral methadone, we can give IV methadone in the equivalent dose. That is possible to do. But remember, methadone, basically long-term methadone, you should have it in your system because of the half-life for a long period of time. If you miss a dose, generally, if the patient's on any sort of high-dose opiate, including methadone, if they miss their dosing in the morning, that should be taken into consideration for the analgesia during the case itself, so that we should be supplementing that in the OR almost immediately. So if somebody comes in on 120 milligrams of opiate, morphine equivalents daily, we should be giving that dose, in making sure they get that, because that is their baseline. Without that, they're going to be not at their baseline, they're actually be less than that. So we should be giving that no matter what in the morning. And especially with patients, we are actually pretty careful about giving that. So the answer is yes, you can. If somebody is on methadone, we can give it IV, but generally we will probably do a conversion to oral morphine equivalents and give that via morphine, because getting methadone, again, it's not just a simple go to the Pyxis and get it out. It is, we have to get it from pharmacy through an order. So it's not quite as simple as just giving the morphine equivalents during the case. But sorry, long-winded answer to yes, you can, but it's not often done.
What about Suboxone? They don't take their Suboxone dose, because I haven't seen many people on Suboxone lately. Are they substituting that for methadone now?
No, Suboxone's a totally different animal. We should, if you're on, so there are anybody, it depends on what the type of reason that you're on Suboxone is, if whether on you're for addiction protocol or whether you're on it for pain management. Okay. Suboxone is a drug that we are very careful about for obvious reasons. High dose Suboxone is very tightly regulated by us. That is a trigger for us to have a discussion with the residents as faculty members. It's always presented, the residents always catch it in their preoperative discussion with us. Or when that's a drug that is always on the tip of our tongues to be able to look at. It's like a beta blocker. We know whether they're on Suboxone preoperatively. If they haven't taken their morning Suboxone dose, they talk to their pain prescriber about what to do. The dosing of Suboxone has changed significantly in the past year or two. It used to be that we wanted them off all doses of Suboxone for about, I think, 5 days prior to surgery. That has completely changed now. It really is dependent on what we're using it for and how it's being dosed. So if they have not taken their daily Suboxone dose, and the recommendation from their pain physician is that they take their Suboxone dose, we actually will give them a dose of their sublingual Suboxone, either from the pharmacy or from their own, they sometimes bring it in. And if they have it on them, we would actually recommend that they take the dose preoperatively. So methadone is not to be used for a substitute for Suboxone. If somebody comes in on very, very, very high dose Suboxone, that's actually an indication to put them on a high dose fentanyl regime and put them into the ICU. If you're talking about somebody who is going to be in a catastrophic situation where they are not able, their analgesia requirements are not able to be met, that's an indication to put them into the ICU with a fentanyl dose. A fentanyl infusion, rather, excuse me. Does that answer that question? Again, long-winded answer, I realize that, but the short one is no, we will not substitute methadone for Suboxone.
That was great. No, thank you. Anybody else have any other thoughts, questions? All right. Thanks, Sarah, for your time, and thank you, Dr. Froman, for zooming in with us today too. We appreciate it.
No problem. We'll see you guys soon. Great job, Sarah. It was a very good presentation.
Thank you, Dr. Froman.
Yeah.